Good afternoon, everyone. My name is Regina. I am the coordinator from Mount Sinai Medical Center. Thank you all for coming. This is our second to last presentation here for the season. We're going to have one more lecture here next month, and then we're going to be back in September. At this time, I will ask everybody to please put their phones either on vibrate or on silent, so that this way the presentation doesn't get disrupted, and Dr. Cusnir could go on with it. Also, please leave all your questions to the end. He will answer questions one-on-one, and then he can also answer questions as a group. Dr. Cusnir sees patients in our Miami Beach location, which is about 5 to 10 minutes away at 43rd and Alton, and he also sees patients in our Aventura location, which is more north, across the street from Aventura Mall. So I'll just have everybody please put their attention to Dr. Cusnir, and again, thank you all for coming.
Thank you, Regina. So we're going to be talking Spanglish. I'll be doing a little bit of Spanish, a little bit of English. We'll start in English. If there's something, we'll kind of like move a little bit in between Spanish and English. I'm bilingual, so that shouldn't be a problem. What I'm going to be trying to cover over the next 20 minutes to 30 minutes at most is a little bit of what I put actually novel therapies in cancer. And it's not that I'm putting that with orthographic mistake. It's actually that's the reason of the Nobel Prize of the past year. So some of the therapies that we're going to be talking and some of the things that I'm going to be mentioning over the next minutes were the reason that the Nobel Prize was awarded last year. Usually the Nobel Prizes are awarded for things that are very remote in making it to patients in the offices. This is something that actually made it this year, and we are already applying these therapies. So this is very exciting. So I'm going to talk about a lot of different things. If somebody wants me to translate something specifically, just tell me Spanish and I'll move to Spanish a little bit, okay? Now the whole concept of personalizing medicine is something that is quite difficult still in oncology. We're talking a lot in oncology and even in a lot of medicine, even when you go to get treated for a urinary infection or something like that, they may get a culture, they may see in the culture that the bacteria that you have is a very specific bacteria, give you that antibiotic, but how does your body react to that antibiotic? What level of the antibiotic is going to reach the area where the bacteria is? It's where we need to get to really make it personalized. And that's actually what we're looking. We're looking that a lot of what I'm going to show you is moving the efforts in personalizing medicine, that we're going to be able to give a treatment to a patient that is very specific for them on their cancer, as well as the way that they will metabolize the drugs and kind of like work them up through the process. And the holy grail of medicine, and this I'll translate at the end of this slide because I think that this is important. The holy grail of medicine is that we're always having a lot of people that we lump together with the same diagnosis, that we could call cancer in this case. And that same diagnosis that you have at this time may have many different treatments. But some of those treatments may be that I can give the patient a drug that is toxic with side effects and not beneficial. A group of patients that they don't get any side effects but also don't get any benefit. Then a group of patients that get toxicity with benefit, and ideally where we want to go is to be able to give the patients a drug that is not toxic and beneficial. That's what we want to do in medicine. That the side effects and that the treatments that we're giving are not going to be something that is going to end up being that a lot of my patients ask me, is the cure worse than the disease? And that's what we're going to do. So en español les voy a decir rápidamente, lo que nosotros estamos tratando de lograr en todas las terapias modernas de cáncer es lograr tener que cuando uno tiene un grupo de pacientes, y si uno mira un grupo de pacientes que tienen diagnóstico de cáncer, el diagnóstico de cáncer es un diagnóstico muy amplio. no es algo que es tan específico, y personalizar la medicina, lograr de que sea algo que nosotros podemos dar un tratamiento en características perfectas. ¿Qué es características perfectas? Hoy en día, cuando yo tomo pacientes, muchas veces les doy tratamientos que pueden tener efectos secundarios y ser tóxicos y que no le den ningún beneficio al paciente. En otros casos yo puedo tener tratamientos que tengan toxicidad, pero que le sigan dando beneficio al paciente, o otros tratamientos que ni son tóxicos, pero tampoco son beneficiosos, darle agua al paciente. E ideal, a donde queremos llegar en medicina, es darle a los pacientes tratamientos que no sean tóxicos y que tengan beneficio. Eso es lo que va a ser la personalización de la medicina, en donde vamos a poder ver que la toxicidad de la droga, de acuerdo a cómo el paciente utiliza su metabolismo y otras cosas, va a ser y permitir que nosotros le demos al paciente ciertos tratamientos sin que tengan toxicidad, pero que tengan beneficio. How do we get there? How do we get to that non-toxic beneficial level? So there's several ways. In the past, we used to be looking to get a biopsy, and we still do it, of like when the patient presents with a mass, with what we think that is going to be a tumor, like in this graph, those blue dots in the center of the diagram, and we had to put a needle, get a biopsy, analyze it, and figuring out what to do. But that doesn't tell us the whole story of the patient, as what we can tell sometimes even from things as simple as looking at the blood of the patient. If we're able to conceive that the whole body is connected, that the tumor is actually shedding a lot of components from the tumor into the patient's blood, and that we're going to be able to capture that blood and maybe even look at the cells that are there and then get that in relation to what is going on with the patient, we might be able to get a better assessment of what's going on. And why is that important? Because the same way that you can tell by looking at your skin, that your skin conceived as a single organ. If I ask you, is the skin a single organ? Everybody will say, yes, the skin is just one organ. But if I take a biopsy of my skin from this area of my body, it will be very different than if I take a biopsy of my palm. Because I don't have hair on this side, on this side, I may have a mole. So looking at the whole body of something that is circulating will capture that heterogeneity. And we've written a lot of articles. I wrote an editorial on this for a major journal, in which we have looked at how many subclones can a tumor have for us to be able to say one drug may be able to target all the clones of the tumor instead of me shooting in the dark. And that's where the studies of looking at tumors in much more detail than just a needle biopsy are important. This is a small specimen of a kidney cancer that was reported in the medical literature, and what they did is that they took that same cancer, and you can tell even from just looking at the bare eye and without being a doctor that the areas look different in this area than what in this area, and that if I were to put my needle for a biopsy here versus here, I may get a different type of tumor. And what these investigators found is that if they sampled the tumor in 9 different places, it looked like 9 different tumors. And it's the same tumor in one place. When you're able to get that circulating cell and that circulating DNA that I was telling you, what you might end up getting is many things. That you may get the actual mutations, and that's what these genetics here are, in which it tells you this is what is driving the tumor. This is what is making the tumor have a speed that is faster than the rest of the body and moving all the time. More important than that, as I manipulate the tumor, as I'm giving treatments, and let's say that the patient met me here in June of 2014, and I gave a treatment and I decreased the amount of tumor that was circulating from 25% to 0.3%, but then the tumor started to grow again. There was a new mutation. The tumor learned what I was doing and became resistant, and I can go and target with a new drug the new gene that appeared. That's the ultimate personalization that we can get. That I am looking forward, feeling what the tumor is doing, and then going, instead of just with a simple X-ray as we used to do in the past. what has that taught us? That has shown us a lot of different things. That has shown us that, like for instance, certain tumors where we do not expect that certain mutations are appearing, and even if it's a minority of those tumors, we're able to treat them very successful. One of the examples that I just picked up was HER2 amplification, which is something that we see in breast cancer. We rarely would have looked at this in colon cancer, and because of these new technologies, we identify now that 5%, not too many, 5%, and it's 5% of the patients have that mutation that we thought that it was only present in breast cancer, in colon cancers. And we have treatments to block that mutation. So when we have that treatment to absolutely block that pathway, we have achieved that the tumor may shrink in this way. So this is after 6 doses of those medications. The tumor is the areas here with the arrows. All these areas are tumors, and look at how the liver looks not even 18 weeks later. That it's improving dramatically. So that's what we are trying to figure out. How do we get to that level to be able to personalize the medication, not based on calling colon cancer, but maybe talking with many last names. When the patients come to my office and sometimes tell me, oh, a friend of mine had cancer and they gave him this medication. I wish that it would be this simplistic. You could tell now that even in colon cancer, we may be using drugs that we use for breast cancer, and that keeps going on and on, that we really need to learn the first name being cancer, then the second one being the location, and then being the genetics. We're getting now really to the base of the problem. What could the future hold? And I have some friends that are working on this, and this is actually not working that well, but it just shows you the concepts of how they are evolving. What we have actually done in some of the cases is that we have been able to even get the cells from the blood of the patient, expand the cells, grow them in the laboratory, implant them into mice models so that the mouse are growing the tumor, treat the mouse, and find out which are the drug that is going to be successful in treating the patient before I even expose the patient to the toxicity of the drugs. The problem with this is that it takes a lot of time. We're trying to figure out how to move this faster so that the patient is not just waiting for months to learn how to treat the cancer, because we don't have that much time. But it is a beautiful concept that we're starting to explore as well. What happened over the past 10 years? And this is a slide, actually, not even 10 years. This is a slide of maybe 6 years only. We started looking that cancer is something that the body recognizes as not self. So that when the patient has a cancer, the body starts realizing, like, this shouldn't be here. And the body is trying to heal itself. There's actually Hippocrates, the father of Greek medicine, used to say, heal thyself, that you should heal from within. And he actually used to follow that in a philosophical manner, in which he used to say that everybody has healing power within them. All that the body needs is the support to heal thyself, to heal on our own. And you're saying, like, this guy has gone crazy. He's telling us that we're going to cure cancer on our own, and that's exactly what immunotherapy is. Immunotherapy is recognizing the cancer and being able to fight it on our own. The problem is that the cancer tends to be smart and starts having blockages to hide from the rest of the body. So the immune system, the same that will fight when you get a cold, the same that will fight when you get a boil in the skin or any type of infection, that same immune system could be in charge of fighting cancer. And we have developed a lot of therapies for that, in which we try to find out the tumor cell, and then the T cells, which are part of our immunity, will find that tumor cell and start presenting it to the rest of the cells and tell them, go and attack. Go and fight these cells. And this is the way that it works. So this is just a schematic to give you an idea of what we do. You have cells that are cancer, that I show you that they may shed these antigens into the blood. In the blood, the immunity recognizes that and takes these proteins that I just showed you, that we could personalize the medicine to the patient, and says like, this is something that shouldn't be here. This mutation and these areas of DNA should be completely out of the body. Pick them up and take them to the lymph nodes, to the glands, to the spleen, to a lot of different organs, and show them to the rest of the immune system and tell them, listen, I think that this is something that we need to fight. After that, our own body expands those cells with fighting capacity or that already learn about the tumor particles, and as they are expanding, sends out cells that are activated. This is like the army of the body, and these are the soldiers. And the soldiers are already deployed, they're ready to go out, and they find that they need more soldiers, that we need to expand them, to keep growing so that not only one soldier can fight this tumor mass, but many soldiers could go out and start fighting. And at that time, reach the tumor and start fighting it. What the cancer does, and what we have learned, and that was the Nobel Prize, is that there's ways that they could hide, even from the point of presenting those proteins. This is the work that gave the Nobel Prize, that part of what is called a checkpoint. And there's something that we have now that are drugs like this one, that is an antibody against that checkpoint, which we call checkpoint inhibitors, that the body will go, fight them, and does not allow the cancer to continue to hide. It's taking the mask out of the cancer and allowing it to be presented. And then that mask is taken out, and then there's another step that the cancer does, that it hides from the soldiers. And there's also drugs that we have developed that we can deploy, block that, and do a dual checkpoint inhibitor or a single checkpoint inhibitor, and be able to go and fight the cancer on our own. We're talking that the toxicity of these drugs, because all that these drugs are doing is activating the immune system, is minimal. All that I'm doing is kind of like giving more weapons to the own body. We have seen toxicities. I don't want to make it that simplistic. We've seen that patients can develop some type of inflammatory reactions and all that. But this is the most amazing thing that has happened to cancer since the history of the war on cancer that Nixon declared in 1971. All the chemotherapy, all the anti-cancer drugs that we developed for the past 40 years, I think that in the future generations are going to say, like, those guys were barbaric, what they used to do. What we are doing now appears to be learning, fixing it, and fighting it. And how are the responses? This is what we call spider plots. Spider plots means that every line is a patient, and I just picked up this slide from one of the meetings, I don't even remember which one, but this is just an example. So if the patient's line go up, it means that the cancer is growing. But by giving that treatment, didn't do anything, the cancer grew. If the lines go down, it means that the cancer is shrinking. And you could tell that by these spider plots that when you have certain type of patients with specific type of genetics that we have found out to be extremely, extremely sensitive to these immune therapies, the spider plots, which are the green lines on these selected patients, most of them go down. So we have not already found out how to fight cancer with our own body, but found out which cancers respond to that. The future is how to make the other ones that are not in these green lines also respond. And we are working on that. There's a lot of research going on there. So at the end of the day, a lot of the patients are going to be faced with this, that the doctor tells you, we found a mass, and then we will tell you, but we have weapons of mass destruction. And that's more or less what I wanted to share with you today, and if there's any questions, I'll be more than glad to entertain them. Thank you. ¿En Spanish? I'll do it again in Spanish. No. Voy a rápidamente hacer un resumen en español. Lo que estábamos hablando en general es que hoy en día tenemos tecnologías nuevas de cáncer que en lugar de dar drogas, que lo que hacen es matar como tal las células. La razón por la cual, por ejemplo, los pacientes con cáncer normalmente perdían el cabello, que eso no lo mencioné en inglés mucho, lo menciono más en la parte en español, es que las quimioterapias antiguas solo seleccionaban por células que están creciendo más rápido que el promedio del cuerpo. El cabello, en muchos casos, no en el mío, pero el cabello en muchos casos está creciendo continuamente, y al dar drogas de quimioterapias clásicas, el cabello se perdía porque atacaba células que están creciendo. Lo que estamos haciendo ahorita es buscar terapias que no tengan esos niveles de toxicidad y seleccionar cómo dar tratamientos en donde activemos al cuerpo propio a atacar al cáncer como tal. Y lo que hemos logrado es encontrar que el sistema inmune puede reconocer muchas de las porciones del cáncer y decir, esto no debería estar acá, esto es algo que yo tengo que salir a pelear. El cáncer es más inteligente, se esconde y tiene bloqueos que le pone al sistema inmune para que no lo encuentre. Ya tenemos varias drogas, no iba a decir dos, pero dos categorías grandes de drogas, por no decir 3 o 4, en donde lo que estamos haciendo es quitarle la máscara al cáncer para que el sistema inmune lo pueda encontrar, buscar, pelearlo, y que sin ni siquiera dar drogas, ninguna quimioterapia, esto nosotros lo llamamos inmunoterapia, no es parte de las mismas quimioterapias, puede entrar el sistema inmune y pelear esto completamente sin que el cuerpo tenga ningún tipo de toxicidad o con toxicidades mínimas de simplemente aumentar el sistema inmune. Entonces, esto es lo que estamos viendo en el futuro. En Sinai nosotros hemos sido parte del desarrollo de muchas de estas terapias, que fue lo que generó el premio Nobel, y con la idea de que en los próximos años vamos a ver incluso mucho más de lo que se está desarrollando y lograr de que estas terapias sean para la mayoría de los cánceres, no para la minoría de los cánceres, que es en donde estamos en este momento. ¿Okay?
Perfecto. Ahora sí. Cáncer es inflamatorio, right?
No siempre, pero en la mayoría de los casos sí.
¿Hay algún estudio porque esto es muy técnico, yo aquí no tenemos el alcance de moléculas tan sofisticado que casi para doctores? ¿Se está experimentando algo con alguna cosa natural que pueda reducir la inflamación si el cáncer es inflamatorio?
Sí,
Pondría dos ejemplos simples. Por ejemplo, el turmeric o el anamú, que son súper antiinflamatorios.
Sí, se están estudiando, hay varios estudios.
He experimentado con mi propia artritis, que tenía esas plantas en mi patio, y siempre me he sentido muy aliviado con la artritis inflamatoria.
No, totalmente. Sí, se ha estudiado todo eso, ayuda, no al nivel de lo que ayudan estas terapias, pero la inflamación es mucho más, yo pienso, que el detonante de lo que genera el cáncer inicialmente. Una vez ya se ha generado el cáncer, la parte antiinflamatoria como tratamiento para el cáncer no ha tenido evidencia tan buena. Incluso nosotros hicimos unos estudios grandísimos de antiinflamación como terapia para cáncer y no fueron positivos. Entonces yo creo que la parte antiinflamatoria y utilizar todo eso disminuye el riesgo, más no genera tratamiento.
Claro, desarrollando también el sistema inmunológico,
claro,
que al final te va a luchar
contra
la célula cancerosa.
Sí.
Y bueno, ¿qué recomienda usted para incrementar la fuerza del sistema inmunológico? Al final el ejército que va a luchar contra.
Sí, eso es bastante complicado. Eso podría ser motivo de discusión de todo un fin de semana, de estar discutiendo qué activa el sistema inmune, pero hay muchas cosas. Al final del día, una vida sana es lo que más ayuda para el sistema inmune. Dieta balanceada, no tener una dieta con cuestiones inflamatorias tipo carnes rojas, cosas de ese estilo. De la misma manera, tener una vida tranquila, meditación, sueño, todo eso es ayuda.
Sobre vitaminas, ¿qué vitamina sería la más apropiada para el sistema inmunológico? Hay muchas, ¿no?
Sí, pero ninguna ha demostrado de beneficio. Todas las vitaminas que se han estudiado para el sistema inmune han sido negativas. Todas negativas. Ninguna funciona. una dieta balanceada es mejor que cualquier vitamina.
Yo he sido paciente de cáncer 3 veces. Ahora yo tengo 6 quistes en la tiroides. Me van a hacer biopsia de tengo 2.4. ¿Qué sería beneficioso?
No, depende completamente, claro, depende completamente del diagnóstico después, pero ahí sí es a nivel preventivo, lo que decíamos de una vida balanceada y sana, pero ya después de eso depende completamente de los diagnósticos que se encuentren, pero beneficioso como tal es realmente hacer el seguimiento médico y estar encima de toda la enfermedad.
Sí, porque yo me imagino, porque yo no tengo un oncólogo aquí, yo estoy en Monsanay, pero porque a mí el cáncer me dio fuera de aquí, de Miami, las operaciones. Pero ahora en esta etapa que estoy pasando por, que no es fácil, pero quería saber si entonces, si fuera positivo, lo que usted está hablando sería beneficioso.
No necesariamente, depende muchísimo. Eso tendría que ser que alguno de nosotros te viera, pero depende muchísimo del tipo de enfermedad. Sí.
Y esta niña que en Italia le curaron, una niña, no sé exactamente la edad, pero bien jovencita, le curaron la leucemia en Italia recientemente.
No, hay muchos casos, hay muchísimos casos que se están manejando. Hay unas terapias nuevas en donde se saca incluso las células del sistema inmune, se saca con la proteína del cáncer y se mandan a un laboratorio externo del cuerpo a entrenar las células en una fábrica de inmunoterapia y se reinyecta. Se está haciendo también eso, y eso fue lo que se hizo con esa niña y es algo que tiene un futuro increíble.
¿En qué consiste el evitar el alimento de la célula cancerosa, el evitar el alimento?
Es difícil porque si bien se supone que las células cancerosas mantienen una alimentación más basada en azúcares, no está completamente probado y es mejor de todas maneras tratar de manejar una dieta baja en azúcares, pero eso no significa que es la solución. Sí.
Es recomendable cuando hay algún órgano con síntomas de cáncer, la histerectomía total o parcial.
Depende de cada caso. Sí, es muy caso dependiente.
Vamos a poner un ovario.
Depende, cada caso es distinto.
No es recomendable.
No, depende, no te puedo decir, no sé.
Depende del grado.
Depende del paciente, el caso, muchas cosas.
El tiempo que lo coja.
Bueno, muchas gracias. Thank you.
So if they have no individual questions, we're done.
Perfect. Regina, see you later. Let me know. I told you 20 to 25 minutes.
I told you, perfect. Yeah. Oh, perfecto. I turned it off. He told me to turn it off.
I sent him a link to the video. Maybe he'll forward it. Her name's Gina.
Yes. Thank you so much.
Thank you.